The plan is just to go through 3 or 4 cases that you'll see in your usual practice. Even as a junior trainee, you'll hopefully come across them. We'll talk about specific cases, but then talk through some of the issues that might arise in the management of the cases. So I'd just like to say thank you to all those that have already spoken, and in particular for this session, we've got Richard Irving joining us from Birmingham, Johnny Harcourt joining us from Charing Cross, and Seb Thomas joining us from Southampton. And I can see you all on screen, so hopefully everybody else can too. So again, thank you very much. So I'm going to just present the first case. So this is a 28-year-old male. He's presented to you with a 9-month history of tinnitus, and he gets occasional episodes of imbalance. Hasn't really got any subjective hearing loss, and when you examine his ears, he's absolutely normal. And then you get an audiogram that shows the audiogram that you can see there on the right hand side. So Richard, can I just ask you what your philosophy is in terms of managing tinnitus and hearing loss in one ear? And while we do that, I think we've got the opportunity to ask the audience what they would do as well. So it'll be quite interesting to see what everybody's thoughts are on that.
Okay, so I'm not going to answer the question, would I scan? I'll leave that to the audience to do. So I guess the issue with unilateral tinnitus is it's about managing the tinnitus. The evidence that we have would suggest that there's absolutely no increase in the incidence of vestibular schwannoma with unilateral tinnitus. And in fact, if you scan these patients, you're just as likely to pick up a tumour on the other ear. So there is a debate about the rationale behind scanning. And certainly the American Academy looked at this, and they have now come down on the side of not recommending a scan. Having said that, I accept that in these patients, you are treating a patient with tinnitus, and a scan can actually be a therapy and not necessarily just a diagnostic investigation. And quite often what I'm trying to achieve with my tinnitus patients is to make them less concerned about their tinnitus and reduce any anxiety associated with that, and that can lessen the impact of the tinnitus. So the reality is, I may well end up scanning this patient, but I would accept that my reasons for scanning is to treat his tinnitus and any anxiety associated with that. And I am not doing this because I think he's at high risk of having a tumour. It's for reassurance. At the end, it's down to clinical acumen. I would talk to the patient, get some sense of how concerned they are, and make a decision. But I don't honestly believe that that case scenario is one that has an increased risk of having vestibular schwannoma.
Okay, and what about the audiogram? We've asked the audience what they would do with that audiogram. What would you do?
In terms of screening, I did look when I did a review on hearing loss for NICE. We reviewed all the screening protocols, and as you can imagine, there is no such screening protocol that is 100%. It doesn't exist. So it's a compromise. And the conclusion that we came to, having reviewed the protocols, was that a simple, straightforward, easy to use approach is a 15 dB asymmetry at 2 adjacent frequencies using the frequencies 500, 1, 2, 4, and 8. And so on that basis, that wouldn't fulfill the criteria. If, however, that patient said, I can't hear properly in my right ear, and his complaint was of right-sided hearing loss, the pure tone audiogram doesn't tell you everything. He may, for example, have some difficulties with speech discrimination, and we do occasionally see retrocochlear lesions having very little in the way of pure tone loss and a discriminating loss. So if he presents with symptoms of right-sided hearing loss with that audiogram, then I would screen. So there is room for clinical acumen in this, but it's down, again, to taking all of that into consideration. But with a history of left-sided symptoms and that audiogram on the right, again, I wouldn't consider that as an increased risk of vestibular schwannoma, and I would defend anyone who didn't scan them.
Yeah, well, I think it's a very difficult one, isn't it? It's always a balance between trying to avoid overwhelming the NHS with the cost of all these MRIs and picking up that very small chance of vestibular schwannoma. Well, in this case, oh, hang on, why is that not changing? We did do a scan, and there was a tumour. And I think what tipped us, I think, was the age of the patient, because it's unusual, and he was a pretty sensible chap. So we did a scan, and it showed this. So, Seb, what can you see there?
So there's it's a T2 scan, and you can see that there's a filling defect in the left IAC, just protruding out through the porus into the cistern. It's almost certainly a small vestibular schwannoma.
Yeah. Okay. And so we can ask the audience actually what they would do for this, but while we're doing that, we can have a chat around that. So what are the options, Johnny, for managing a small vestibular schwannoma like that? Johnny, can you hear me?
Yes, I can. Sorry.
Sorry, just wondered what the options would be. Can you quickly run through?
Okay, so as with all new diagnoses, we would explain the likely diagnosis. As Seb says, it's a small lesion. I mean, one of the features is that it is filling really the whole of the internal auditory meatus, which if you were in a unit where you considered hearing preservation surgery, that might come into your decision making. When we were just talking about scanning and finding a lesion, one thing I'd always consider in the younger people, could there be any NF2 implication? Now, we all know that if you found a schwannoma in an adolescent, you would definitely think about that, not in a middle-aged person. I'd be curious to know what Richard and Seb think about whether in a 28-year-old you would even trigger that thought without any other features of other lesions, bilateral or meningiomas. But anyway, I'd certainly favour watch, wait and rescan. So as always, you explain all the options to the patient. It's for them to decide. But I would expect in the majority to agree and then to rescan in 6 months.
Yeah. So going back to the issue on NF2, I mean, what are your thoughts about investigating that in a 28 or 29-year-old chap?
So we do have guidelines, and I think it was Gareth Evans from Manchester who put this together. And NF2 screening, if we pick up a unilateral acoustic under the age of 30, the risk is pretty low, but we would do a genetic test under the age of 30 for unilateral.
Yeah, yeah, I think we would. I mean, given that I'm in the same department as Gareth, I think we're kind of obliged.
It's worth bearing in mind that it's symptoms under the age of 30. So if you've got someone with a 5-year history who's in their early 30s, you probably ought to think about it.
Yeah, definitely. Okay. So where's that not going forward? So we've asked the audience. So we do the rescan a few months later, and this is the new scan, and you can see that there's definitely been an increase in size. So we're going to ask the audience again what they would do, but what would your advice be now with a significant growth in a patient of that age? Let's assume the NF2 thing was negative.
Well, if that's to me, I mean, this is clearly a biologically frisky lesion. It's in a young patient. That's considerable volume increase over a first cycle of scanning. But as Mike said in his talk, you really notice such an event over a short period between imaging. So this is a time where, considering treatment, you would strongly recommend to the patient, of course, always their decision. It's still comfortably within the angle. There's no brainstem compression, but out of choice, I would favour radiotherapy in this situation, where there's been, I presume, no change in his hearing function. And so there is hearing to preserve. Surgically, I don't think that's easily feasible. There are obviously issues in irradiating young people. Rupert mentioned this with glomus tumours, but the chance of malignant change, as far as we know, is extremely remote.
Richard, what would you be of the same opinion?
Very much so. I think, first point, strongly recommend doing something. I think it's hard to sit on this any longer. I don't know how many months this was, but this is a rapidly growing tumour. So you would predict in a relatively short time frame, he's going to get symptoms. And it's of a size where he still has the option of radiotherapy or surgery. So I discussed both of those options with the patient. If the patient then said, well, what would you recommend, which is not an unreasonable question, I would align with what Johnny said. I mean, it's hard to recommend surgery over radiotherapy in this size of tumour, looking at all risk associated with both interventions.
Yeah, and are there any medical therapies available or on the horizon for this type of tumour?
There is a paper suggesting that aspirin may have a, non-steroidals, but aspirin in particular may have a role. I personally have never used it, and I think you'd be a bit foolhardy to try it in such a rapidly growing tumour.
Yeah, I think we're not ready to do that, are we really? And there are some medical therapies that we use in NF2 that are quite effective.
Not licensed in this situation.
No, but definitely NF2, they've been very effective. Okay, so that's our first case. So we're just going to move on to the next one. So this is an 82-year-old chap who's non-insulin dependent diabetic, no previous ear problems, and he's had otalgia for 6 weeks. And when you look in the ear canal, there's a polyp in the ear. He's got a really subtle right-sided facial weakness, but no other cranial nerve palsies. And he's got a bilateral presbycusis and a right conductive hearing loss. So what would your initial management be for this patient? We're going to ask the audience, and I'll ask Richard if that's okay. What would you start off with?
So if there's, I'm going to do an MRI scan. I'd probably do a CT scan as well. If there's a clear polyp that's easy to take in clinic, I would take that out and send that as a sample. But the story looks very much as if we're heading in the direction of the skull-base osteomyelitis. Yeah.
What's the differential diagnosis in this situation?
So the main thing I'm trying to exclude is malignancy.
Okay. Yeah.
Everything else is extremely rare.
So, and what are the sort of symptoms that would kind of point you in the direction of a skull-base osteomyelitis compared to a normal otitis externa?
So it's not just the symptoms, it's the clinical picture. So elderly, diabetic, pain, and cranial neuropathies are the key features that you're going to see in the osteomyelitis cases.
Okay. And in terms of imaging, what sort of imaging would you do in the first instance?
So CT and MRI with gadolinium.
Okay, yeah. So so this is his CT scan. So I've only got 2 slices up because I can't show the whole sequence, but you can see if you compare the left side with the right side that there's some erosion around the temporal bone. There's fluid within the mastoid, and if you look at the clivus compared to the left side, there's definitely some bony erosion in that position. So it gives you some indication of what's going on, but it's not the most sensitive investigation that we can do. So the MR scan is definitely really helpful in these cases, and this just shows you 3 different sequences in the same patient. So you can see this avidly enhancing lesion in the skull base, affecting the area around the temporomandibular joint. It's affecting the prevertebral muscles and the pterygoid area, and you can see the loss of the fat planes in that area. And if you look at this slice, you can see quite obvious inflammation around the pinna. So that's kind of confirmed the diagnosis. And your biopsies come back negative. You've done a swab and it shows Pseudomonas, and the inflammatory markers are raised. So one of the key issues here is how long you would treat the patient for. And it was interesting seeing the delegates and how long they would treat it for. But how long would you treat this patient for, Seb?
Well, he's got really quite extensive disease. It's going medially up to the synchondrosis, almost into the clivus. He's also got a lot of risk factors. He's 80, and I think you said he was diabetic. So this is someone I would have a conversation with microbiology and say, look, I think this is one to go beyond the usual 6 to 8 weeks and probably head for 2 to 3 months. Of course, other things influence your decision making. How quickly does his pain respond is a really good factor. You know, patients who respond within 48 hours, you know that they're going to respond well. It's also a very good way of confirming the diagnosis. It also depends on, you know, are they someone who's going to control their diabetes well, or are they an erratic person who's going to need a lot of help with that?
Yeah, and do you think there's a place for radionuclide investigations in these cases? Well,
before this morning, I would have said to you no, and certainly our radiologist, who also, our head neck radiologist, who's also a radionuclear radiologist, would said there's absolutely no role for it. I'm really interested to hear about that PET paper from this morning. That's something we'll look at a bit more closely. Yeah. But it's not something we've used, the false positives being so high. It's only really useful if you get a cold result, and it's rare. Most of the time it's warm or hot, in which case you're no further forward.
Yeah, I agree. That PET study looks really interesting, but we don't use it in our department. Johnny, Richard, do you use it?
No, we've similarly, we've had that debate recurringly with the imaging people. One thing I would just say as we develop the case, what I always tell the team at Imperial, when these patients come in, particularly if their imaging is like you've shown in this case, you need to meet with the patient and the family really early on and say to them, this is really serious. And at the level of infection, inflammation you show in the imaging, I'd expect a 30 to 40% mortality from this condition. And when you introduce these concepts later on and they say, what, from an ear infection, my dad is going to die. I mean, you've got to be very realistic. And we certainly largely manage these through the infectious diseases department, because these are patients with complex medical problems who largely will be either inpatients on IVs or through with OPAT treatment with intravenous medication, and particularly if they are swab negative. So in the patients with a positive swab, you're on firmer ground. But if the patient's been knocking around clinics for a while, there's never been an accurate representative swab, then you're going to struggle.
Yeah, no, I agree. And what about fungal disease? I mean, that's one of the things we've kind of struggled with some of the patients that we've got that haven't responded to IV antibiotics. Do you? I mean,
it often, when it's extensive and there's dural involvement, the radiologist will often report a possibility of fungal disease, and it is not unreasonable to give voriconazole as an adjunct in case it is primarily fungal. But in fact, voriconazole is unbelievably expensive to give over a fortnight's course, and you've got to have a reasonably sensible foundation for making that decision.
Yeah. Seb, how often do you see complications from these sorts of things? And we look in the textbooks of Gradonegos and other types of abscess that you might see. How often do you actually see complications?
I think the commonest things we see are jugular Freeman syndrome. So the disease extends to cause a vagal paralysis in particular. And that's a disaster for an 80-year-old because they start aspirating and then they go off. They're already 80 and comorbid. The other thing that we see with very extensive disease is internal carotid involvement. And that usually, you get a stroke. And again, that's usually a disaster in an 80-year-old. And those are usually the two mechanisms by which these patients die. Of course, it can go on centrally, infect other cranial nerves, the 12th. You can get intracranial abscesses sometimes. But those are the two things that I've seen commonly.
Yeah, yeah. Okay, so I think there might be some questions, but for some reason I can't see the chat on my screen. So I've asked Sean to field the questions.
Just going back one question, Simon.
Yeah, sure.
Interested to see what others in the panel think. One of the things we found locally with regards to fungal disease is that S16 fungal PCR has started to pick up these that we hadn't previously suspected. So these are people we're diagnosing as bacterial Pseudomonas, but we're also getting a second result a few weeks later saying, hold on, there's probably fungus in this.
Okay, so they do that on the biopsy or the microbiology?
On the swab usually.
Swab, yeah.
So one of the problems obviously is it depends on where you get your sample from. So if they've had endless rounds of topical antibiotics into the ear canal, it's quite common that you'll pick up fungal strains within the ear canal, but it may not be representative of what's happening. Now, I'm sure all of us get regular calls. So these patients are at Imperial largely managed by infectious diseases, and then if they're not doing so well, they ring us up and say, can you take a biopsy? And the question is whether you give in to that and do a skull-based biopsy of whichever way you want to do it. Thoughts? I'd be curious to know.
Yeah, I mean, we've used antifungal agents much more frequently in the last couple of years than we have in previous years, and you sometimes can see it on the scan. There are some typical features of fungal disease that it can indicate that you should treat with fungus, but sometimes you can't. So I think the PCR and the biopsies probably will be helpful in those cases. Sean, are there any questions?
There are. So just one of the questions is, in the literature, some authors stratify NOE severity based on sites involved, so Clivus, TMJ, etc., and give longer duration of antibiotics intravenously in the first instance. Does the panel feel there's any value of that? So stratifying time per site.
Yeah, Richard, do you want to answer that one?
I think the main issue we see with these is too short treatment. And patients being treated, appearing to get symptomatically better, and then reappearing again a few weeks later, the disease clearly wasn't controlled and it's taking off again. And that can be very difficult to manage. So going back to the question you've got on the screen, these are managed for vast majority, a minimum of 3 months of antibiotics. It's a long-term treatment. It's a serious condition. And so I think the stratification has some merit to give some indication of the severity of disease. But that said, I take all of these seriously, and they're all on long-term antibiotics. I don't think there's any such thing as a short course for these patients. You will get your fingers burnt by cases that come back. They're frail, they're elderly, they're immunocompromised. It's hard to eradicate this bacteria in these cases.
Yeah. What about switching to orals? How do you feel about that?
We try and give IV and put in a line and send them home, and they have home visits and get IVs twice a day. So that's my preference for these patients. Many of them end up on meropenem, so they're getting that IV on a regular.
Yeah, I mean, I think that's the key message for everybody to take away, is that this is not a short-term treatment. You've really got to take it seriously. And, if you treat for too short a time, you then get a recurrence, and that can potentially have a very negative impact on the patient. So sorry, go on.
So I was just going to say, monotherapy with Cipro only is asking for trouble unless you've got very limited infection, just limited to the tympanic bone. Because the organism becomes resistant. Yeah.
So I'm just going to move on to the next case. So we've got some pictures. He went on to meropenem, as Richard mentioned, and these are his scans for the sort of 6-week period afterwards, and then I've got the next 6 weeks there, and you can see that the amount of inflammation's actually reduced, the enhancement around the ear canals reduced, the fat planes in the pterygoids is starting to come back, so he responded really well to the antibiotics, and when you look at his subsequent 6-week scan, you can see very much improved. So he actually responded really quickly to the antibiotics, but we don't often see such a profound change in the radiology, and that's one of the difficulties that we have, is that, you know, the changes on the radiology don't really reflect the clinical improvement. So you can't entirely use radiology to determine when you stop the antibiotics. So so this is the third case. So sorry, I've got a dog in the background that's making a lot of noise. So this is a 25-year-old male, left-sided hearing loss with pulsatile tinnitus for 9 months. And when you look in his ear canal, he's got a lobulated polyp, and he's got a conductive hearing loss, no other cranial palsies. And he's got a brother that's also got some hearing loss on the right side. So can you just tell me what your differential diagnosis would be of somebody with pulsatile tinnitus, and then perhaps go on to explain what you think the most likely thing is in this scenario? Johnny, would that be okay?
Thank you. Well, in terms of pulsatile tinnitus, it's interesting as we consider the scanning protocols for unilateral central hearing loss. In a similar way, if you've got a patient who has got unilateral pulsatile tinnitus, who has got a normal otoscopy, different from this case, we locally have for years done CT of the head, arterial and venous phases, so looking for AVM, vascular intracranial tumours, as well as glonuses in the skull base. There is a natural shift towards MR, A and V as the more modern style, but again, it's more expensive, it's slightly more complicated, and imaging is going to be a huge problem for us as a community over the next couple of years as we catch up after COVID. So in this case, there's a lobulated polyp. I mean, it is possible it's a localized issue within the deep ear canal, but imaging should be able to tell you one way or the other. I wouldn't immediately biopsy, I would image and do probably a CT as my initial imaging modality. It's interesting that the brother has also had a problem which is investigated, but it doesn't really drive us in any particular direction.
Okay. So what would be the things at the top of your mind? What do you think the most likely diagnosis is in this?
Well, again, if the polyp is a sort of mature epithelialized, it's more likely to be a deep-seated disease which is extending into the ear canal. So a paraganglioma would be high on my list of diagnoses. It could be a localized skin adnexal tumor. It could be a cancer. So getting imaging first would be good to, before deciding, obviously, biopsying a possibly vascular tumour is something you're trying to avoid.
Absolutely. So what sort of imaging would you do?
So I'd probably, in the clinic, if the patient was well and this has been a persistent issue, I'd probably just do a CT scan of the temporal bones as my initial management.
Yeah, I think that's probably fair, isn't it? Because you don't know for sure what it is, and the CT will give you enough information to then plan any subsequent investigations. So actually, we did both. We did an MR and a CT. I'll show you the CT first. This is the left ear, right ear. You can see the right ear is beautifully pneumatized. The anatomy looks really lovely. But on this side, you've got a bit of fluid in the mastoids, some bony erosion around the jugular foramen, and then you've got this kind of mass within the external auditory canal that is also partially within the middle ear space as well. And if we go back to the MR, you can see that there's a enhancing lesion. So this is a T1 weighted scan with gadolinium. Seb, can you just describe the sort of typical radiological features that you'd expect to see with a paraganglioma, which is what this turned out to be?
So it's an enhancing mass. You can see lots of flow voids, those little black dots. Sometimes it's called a salt and pepper appearance, which represents flow voids within vessels. The epicenter of the tumor is the jugular vein, jugular bulb, and you can tell where that is in relation to the carotid, which is just anterior to it. If it was a little bit more lateral and a bit more posterior, you might think about endolymphatic sac tumors, but you can see clearly the epicenter of this is the jugular foramen.
Yeah. So
the fact that it's causing all of that bone destruction and that sort of rotten bone that you described is also very typical of paraganglioma.
Yeah, so I mean, this is pretty clearly a jugular paraganglioma, isn't it? But if it was a small tumor, how would you differentiate it between a tympanic tumor and a jugular tumor?
So the key is whether the dome of the bulb is involved, and sometimes you need to look very carefully to see whether that's breached. And often the best way of doing that is looking on the coronal, not the axial.
Yeah. Okay. So, Sean, I put these questions together. Sean thinks this one's a bit hard. Oh, it's gone. We alluded to the fish classification. How would you classify this tumor?
This is at least a C, and possibly it's got an intracranial involvement, so it's a D.
Yeah. So you can see on the slide on the right that there's some intracranial involvement, so it would classify as a D. I mean, I find the classification not particularly helpful because the tumours can affect all sorts of areas of the carotid artery and go intracranially, and there isn't one particular classification that they fit into necessarily, but we'll skip over that because that's kind of too detailed. So this is the coronal imaging, and you can see really nicely this enhancing tumour in the skull base. And you just kind of get the hint of perhaps something else lower down, and also this sort of tongue of tumour coming down into the jugular vein. And as you look at different slices, you can see on the coronal a separate lesion here, and on the axial scan another lesion there. So Richard, what do you think that second lesion might be?
So he's a young man with multiple paragangliomas. As I say, it's likely to be a paraganglioma. It looks of similar appearance on imaging with flow voids. We know that in this age group, a genetic causation is more likely than not. So he probably has hereditary paragangliomas. At that level, I'm trying to work it out. It's possibly a vagale. I'd need to see other images to confirm that. It could be a carotid body tumor, but I think it's probably a bit high for that. So I'd go for probably a vagale. But again, another paraganglioma. It's separate from the first. So I think he's got multiple tumors on that side of the neck.
Yeah, I think we felt that it was probably a vagale as well, because it was a bit too high. Okay, so you alluded to genetics. So what other investigations are important for somebody that presents in this way, Seb?
So we know at least 30%, maybe more, of these have a familial genetic tumor mutation. All of these patients in our practice under the age of, the only exception would be an elderly person with an isolated tympanic lesion are sent to the geneticists. They're looking principally for STHD and B mutations. They're 95% of those are those two mutations. If they're positive, they get plasma metanephrines. They get a CT chest, abdomen, pelvis. That's most of the starting investigations.
And is there any one particular genetic mutation that is associated with more severe disease?
So D tends to be more associated with multifocal disease, and B with malignancy. They're both not great, if I'm honest.
No. Richard, you were going to say something?
Yeah, so I tend to remember it as B is bad and D is dad. So B's where we see the more aggressive disease, the metastatic disease. Virtually all of our cases with metastatic disease have been Bs, and abdominal malignancies more often in the Bs. So the B is the one that you don't want, and the D is the one that's characterized by genomic imprinting and inherited through the paternal line. So I think B is bad news. Really.
It's a bad one. Yeah, yeah, that's true.
Again, in sort of terms of how you manage them, I mean, these patients are all managed by the endocrine team. We're lucky at the Hammersmith. There's a World Centre of Endocrinology. It's enormous. So the patients go there for all this complex investigations, which is beyond the scope of us as ENT skull-based surgeons. And I'm constantly amazed at how often they find associations with other genetic conditions, subtle forms of multiple endocrine neoplasia, intracranial issues, all sorts of things. And it's so important to have a friendly endocrine service who can manage that side and counsel the patients.
Yeah, I mean, I think it's critical to manage these in a multidisciplinary team, isn't it? And you need to have that genetics and endocrine input to get them managed appropriately. Okay, so we've seen that. So he had a full body MR and thankfully didn't have any other lesions, and he was SDHD positive. And actually his brother that I mentioned in the history turned out to be SDHD positive too, and has a paraganglioma too. So it's a very unfortunate situation for the family. But he's negative in terms of the endocrine, and we don't see that many patients with endocrine disorders with jugular paragangliomas, at least. So again, it's the medics really that tend to deal with those with the pheochromocytomas and other types of tumour. So how would you treat this initially? So we've got the audience; they can answer the same question. So Richard, what would you do initially for this patient?
So we'd work them up, and actually our clinic in Birmingham, we'd get the endocrinologists and the geneticists and the head and neck guys and ourselves, and we see all these patients together. So we have very much a combined clinic, so we get involved in that side of the testing. And but you're right, you pick up some strange things. And going back to that previous case, if you found that the metanephrines were raised, it's probably more likely there's a pheochromocytoma than it's one of the head and neck lesions that's producing the metanephrine. So it's just, you know, important points to make, really. So we'd work them up. And in terms of what we do, the vast majority of them, we watch. I think you look very carefully in terms of what problems the patient is having, what symptoms they're having, what difficulties they're having, and whether or not you can alleviate them with any intervention. So for this particular patient, I think if his ear was particularly symptomatic and that was problematic for him, I'm not sure based on the history that's necessarily the case.
Is there any place for early surgery in a patient like this, or radiotherapy?
The fact that he's got a polyp in his ear canal is potentially going to cause problems. You can irradiate those, but often you end up with a suppurating, bleeding mess in the ear canal. So this is someone you might end up, maybe after a period of observation, with a combined treatment. So certainly limited surgery, lateral to the jugular bulb, lateral to leaving the, but removing that disease from the ear canal. In my experience, it's really difficult to keep the drum and keep the medial canal skin intact, and you often end up doing a blind sac closure with those because the canal skin is so destroyed. But if you can preserve it, you can preserve it.
Yeah. Okay.
And then you don't deal with the medial aspect. That needs potentially at some point radiotherapy.
Yeah.
I lost you on one computer and I'm now on another. So
yeah.
we've got three set up at this point. We back up. Always have
things before. So okay, so Seb, you're psychic. This guy did actually run into pretty significant problems with bleeding from his ear, and we did another scan, and this is only a year or so later, and the tumour had actually got quite a bit bigger in that time, and he developed more tumour in his ear canal as well. So this is the scan, the second scan that he had, and this is the one just to compare it to. So it was 37 by 49, and the follow-up 32 by 42 in the first one. So, you know, we were in a difficult position with him having lots of bleeding from his ear canal, and we decided to do exactly, well, we planned to remove it, or part of it, as you said, and do a blind sac closure. And this is his embolization, which shows the very nice blush that you get with these tumours. The problem we had was that he had a lot of blood flow from the vertebral, as well as the internal, the carotid artery, and we couldn't embolize the vertebral. So embolizing it was really difficult. But we did a blind sac closure anyway, and debulked the lateral part of the tumour just to get rid of it from the lateral part of the temporal bone, and it bled like mad, but we managed to do it. Okay, so we've got about 2 minutes left. I don't think we've really got a lot of time to discuss the next case, which is a petrous bone cholesteatoma, but I'd like to thank you all for taking part in the day or the morning. It's been a really interesting experience. I've learned a lot, and it's been nice to see everybody. We haven't really had a chance to meet for the last 2.5 months, so thank you again for taking part.